Good morning. I wanted to start by thanking Greystone for hosting this fabulous event. We've had the privilege of working with Greystone for nearly a decade, and as good as I thought they were in 2003 when we developed our first project, as the market conditions have changed, we've really seen them work wonders, so thank you. I'm going to start by walking through the June 26th Supreme Court decision upholding the constitutionality of the individual mandate and the Medicaid expansion provisions of, there are a million acronyms, PPACA, we're just going to call it the Reform Act, or the Act, because I think we love acronyms in healthcare, but the individual mandate requires virtually all residents in the United States to obtain minimum essential health coverage by January 1, 2014. If you fail to purchase the insurance, you are subject to a shared responsibility payment that you have to pay with your income tax to the Treasury Department. The Treasury Department doesn't have authority to penalize you for failure to pay. So the majority decision, the majority opinion, in a 5-4 decision upheld the constitutionality of the individual mandate, but not under the Commerce Clause, which I think most people expected. The majority decision held that the Commerce Clause did not require the government could not require individuals to purchase a product that exceeded the Commerce Clause. 4 of the justices who joined the majority opinion disagreed and felt that the Commerce Clause, because healthcare is universal and unique, and everyone will require healthcare at some point, and because failure to purchase healthcare impacts the healthcare as well as the insurance markets, it substantially affects commerce. So the majority then went on to consider the taxing authority and said that this individual mandate was permissible under the taxing power. So the court said that even though the government couldn't require individuals to purchase the insurance, they could tax them for failing to do so. So interestingly, the initial question was really whether the plaintiffs had standing. And under the Anti-Injunction Act of 1867, you cannot challenge tax payments until after you pay them. So this would have been in 2015. But the court said, for purposes of the Anti-Injunction Act, we're going to defer to the congressional classification of the payment as a penalty. So it's not a tax. So the reasoning was that for constitutional purposes, we're not going to defer to the legislature, but the legislature can determine that this is a penalty and not a tax for other legislative purposes. The second issue was the Medicaid expansion. And the Act requires states to cover individuals with incomes up to 133% of the federal poverty level. That's about $30,000 for a family of 4. The court held that the Medicaid expansion was permissible. You could expand the class of eligible beneficiaries, but you could not force states to participate. So you couldn't condition participation in the Medicaid program on expansion of the coverage to these individuals, basically making the Medicaid expansion a voluntary program. Interestingly, the dissent would have held both provisions unconstitutional and held that they could not be severed from the remainder of the Act, so in fact the whole Act would have been held unconstitutional. So where does that leave us? There is still litigation trickling all around the country on different provisions, not these 2 provisions of the Act, but I mean, I think we all recognize this is not going to be settled in the courts. This is frankly going to be settled in November at the elections. As recently as this week, the House voted to repeal the Act. It was largely a symbolic gesture because I think this is the 32nd time they've done that. And obviously, it's not going to, the Senate and the President aren't going to allow that to happen at this time. In addition, I think that states are very active. And for example, just this week, Governor Perry here in Texas said that Texas was going to join 5 other states in electing to opt out of the Medicaid expansion provision and the state insurance exchange provisions. So I think we're going to see a lot of interesting developments politically, and I think no matter what happens, Gary had the best point, which is even if we don't have the Affordable Care Act, we're going to have change. Private payers, state initiatives, no one is thinking fee-for-service is the way to go. And they really want to focus on quality, efficiency, and patient-centered care. Oops, sorry. So I'm not really going to talk about the opportunities, other than to briefly talk about ACOs, because I think that Gary and Sue are going to cover the others. But Gary said that they've already started an ACO. I think he is one of 154 ACOs at this time. 89 just joined as of July 1. An ACO, the Act authorized, implemented the Medicare Shared Savings Program, and that established accountable care organizations. Hospitals and physicians are allowed to form a new entity. It has to be a new entity. Form a new entity to provide care to Medicaid fee-for-service beneficiaries. They will not be reimbursed under the traditional fee-for-service program, but they will share in savings. And if you want to be a little more courageous, you can share in more savings and risk sharing in the losses as well. Skilled nursing facilities can participate either as members with a controlling interest or as contracted providers. I have gone back and forth so many times thinking about the role that CCRCs can play in accountable care organizations, and I think if your state doesn't have restrictions on outside admissions, which is about half the states in this country, you can participate either as a provider or as a controlling owner. So has anyone gone forward or participating in this? Well, maybe next year we'll have more to talk about for what's going on there. Along with the carrots that come with quality and improving efficiencies, there are some risks. And Gary mentioned the readmission penalties, which, to be the optimist, actually is a great opportunity to strengthen relationships between acute care and long-term care providers. I won't go into the other one, except I think it's worth noting that the Medicaid payment adjustment for health-acquired conditions, it has applied for the Medicare context for hospitals since 2008. It applies to hospitals now, but the Act authorized states to expand the settings for which they would not pay for care conditions that are preventable. So this, I think that's inviting the states to regulate and limit compensation, reimbursement for those kind of conditions. I think Sue is going to address this. The one thing, and I think Sue's going to talk about this, that is key here, I think, is information technology. It's very easy to talk about all these wonderful initiatives and changes, but to actually make them happen, there's going to have to be a lot of transparency, a lot of evidence-based quality reporting. So there's a lot it's easy to talk about this. I like being a lawyer because you can tell people what the law is, but to put it into action is incredibly challenging. Same thing, I think that Sue and Gary are going to have covered this or will cover this. I wanted to talk a little about ACOs because I think what the regulators have done here is very interesting. When the initial proposed regulations were issued about accountable care organization, the comments that came back were, how can we do this? It's inconsistent with a lot of our compliance requirements, specifically the fraud and abuse laws, for example. And I think that the regulators did a great job of responding to those concerns. And this is good because, as all of you know, for as long as there has been healthcare, there have been regulation that has restricted your ability to engage in innovative delivery models. So even though the guidance is limited to the ACO context, I think it's a good sign that the government is opening the door to thinking about not just technically applying these compliance laws and allowing providers to be more innovative. There also gives you a roadmap as to what they want to see, and basically what they want to see is that whatever you're doing it to improve quality, to improve patient care, and patient-centered care, which is a big movement. So the Office of Inspector General and the Department of Health and Human Services issued waivers for the fraud and abuse laws in connection with ACOs. So the details of that are, it starts with startup costs. If you're developing your infrastructure, even if you don't eventually form the ACO, if you think you're going to form it and it's reasonable, your efforts, any of the compensation and other structures that you've entered into will be exempt from the fraud and abuse laws. Any of your operational costs. So this is huge because it's not just the contributions providers make to engage in the ACO, it's the payments they make to physicians and other providers to incentivize them to reduce care and limit care, which would have implicated the fraud and abuse laws, but as long as you could show you're not limiting medically necessary care, that's acceptable. And a huge statement was that incentives and inducements to patients to receive care, preventive care, et cetera, would also be within the waiver for the fraud and abuse laws. And finally, I'm sorry, the cost sharing, the cost savings, that's big too, because those distributions, the way you use and distribute them, will also be exempt from the fraud and abuse laws. The antitrust regulation, the Department of Justice and the Federal Trade Commission issued guidance creating a safety zone for providers, ACOs specifically, from the price fixing and market allocation restrictions, so that was also tremendous. And for the tax-exempt providers, the IRS issued guidance that accountable care organizations, that is a charitable purpose. That was a big acknowledgement. There was an issue about whether it would be considered charitable. There was also good guidance about when you enter into, if you're a tax-exempt entity and you enter into a venture with a taxable for-profit, would that be considered a private enormement or another impermissible benefit? And the IRS said no, that would not be the case. And finally, that the cost sharing, I keep saying cost, the savings would not be considered unrelated taxable business income. So I think that is all really good news, specifically for ACOs, but also for providers thinking about other delivery systems. So I thank you. I pass you on to Sue.